Welcome everyone to today's webinar, Medication Considerations for Fall Prevention and Fall-Related Injury. Today's webinar is facilitated by the Loop Fall Prevention Community of Practice. My name is Michelle Dukeman and I am the manager for the Fall Prevention Program at Parachute. I'm going to go over a few housekeeping items next, but while I do that, we'd love to see who's joining us today. So if you can, please let us know your role, organization, and location, and that will give us a good sense of who is joining today. So thanks in advance for doing that. All right, and I'll move on to the housekeeping. During the webinar, if you have questions about the technology, please type them into the chat box. My colleague Marguerite will be monitoring this. If you have questions for our presenters about their presentation, or presenter rather, about their presentation, please submit those questions through the Q&A box that appears at the bottom of the Zoom window. Questions for our presenter will be answered at the end of the webinar, and you'll only be able to view questions that you have asked, not questions posed by other participants. As a reminder, the webinar is being recorded, and a link to the recording will be sent to all participants in a few days, along with the link to the presentation slides. A reminder that our next webinar is on November 28th and focuses on reducing the risk of falls by removing environmental hazards. And this is the third and final webinar in our Move, Improve, Remove series for Fall Prevention Month. Today is the second webinar in that series. The series is meant to celebrate the new posters that are available for download at NoCross across Canada. Each webinar focuses on one of the three posters calls to action: move your body. Today is on improving your health, and then the final call to action: remove hazards. Webinar recordings are available on Loop or on our YouTube channel if you weren't able to attend the November 7th webinar, or if you're not able to attend the November 28th webinar in this series. A little bit more about the posters, which I will circulate that information with the post-webinar package, but the posters are available in French and English. They're targeted towards older adults, and they're designed to be posted in a variety of settings like hospitals, clinic waiting rooms, pharmacies, etc. So please feel free to download those and post those in spaces that make sense for you. Many of you on the line are already Loop members, so thank you for that. But if you are not already, we encourage you to sign up. Loop is the no-cost online platform for the Fall Prevention Community of Practice, and it brings together its members from across Canada to problem solve and discuss how to implement evidence-informed and promising practices in fall prevention. Listed on the slide here are just a few of the services and features that Loop has. And as a reminder, I know we'll get this question again, but I'll say it again, the recording link and presentation slides will be posted on Loop in a few days. I'd like now to introduce our presenter. Chris Fanlon is a board-certified geriatric pharmacist with more than 20 years of experience. Since 2021, he is a pharmacy clinical coordinator based at the Veterans Center of Sunnybrook Health Sciences Center with a focus on palliative care and geriatric medicine. Chris is an active educator, and he teaches learners of various disciplines at Sunnybrook as well as at the Faculty of Pharmacy. You can find a complete bio for Chris on Loop, but without further ado, I'll let you take over, Chris.
Great. Thank you for that introduction, Michelle. Let me just share my slides. Is that looking okay?
Looks great.
Awesome. So thanks, everyone, for attending this Loop presentation. I wanted to begin with a land acknowledgement, and I'm thankful to be broadcasting here in Toronto from Sunnybrook. And as we know, land acknowledgements are only a starting point for larger conversations, and one can consider concrete acts towards reconciliation. So I have no potential or actual commercial conflicts of interest with respect to this topic as part of my formal disclosure. I am an employee of Sunnybrook Health Sciences Center, and I do have an academic appointment with Leslie Gann Faculty of Pharmacy, U of T. So the opinions expressed here are my own and may not represent Sunnybrook or the Faculty of Pharmacy. I have done some work as a speaker, as a reviewer and content developer for several organizations as well outside of my employment. So I wanted to begin by going over just an outline of what I wanted to go over with everyone here today. Just a little bit in terms of some falls and fall-related injuries in Canada, some of the basic epidemiology we can understand for contextual purposes. Then I wanted to explore the structured approach to medication review to help address medications as falls risk factors, as well as the role of medication review and deprescribing to reduce fall risk, and how they're incorporated in multifactorial assessments, as well as looking at a couple of medication and fall-related injury scenarios that sometimes you might see often in the community setting or long-term care or in hospital practice. So each year in Canada, between 20 to 30% of seniors fall, and fall-related injuries are the leading cause of injury-related hospitalizations among older adults. Resulting injuries can cause substantial disability, reduce mobility, increase risk of death, as well as negative mental health consequences, including fear of falling, confusion, depression, and increased isolation and dependence on others. About 1/3 of fall-related hospitalization often involve a hip fracture, and falls resulting in a head injury are a common concern for older adults. And advanced age, as well as anticoagulation that they might be on for other disease states or conditions, are thought to be associated with an increased risk of intracranial hemorrhage. So that just sets the stage of what we're going to be talking about today. Now, over the last decade, falls among older adults continue to be a serious public health issue. Emerge department visits and mortality rates show an upward trend. And this is data from the Public Health Agency of Canada for the past decade or so. And it shows that about just a little over 5 to 6% of people aged 65 years of age and older actually reported having a fall injury in the past 12 months. And so the PHAC data from 2008, 2009, spanning all the way to 2020, not including Quebec, the annual number of fall-related hospitalizations of persons aged 65 years of age and older rose from just under 50,000 to about 72,000. So that's almost a 50% increase if you think about the numbers. And the number of Canadians 65 years of age and older requiring hospital admission for fall-related injuries is growing. Now, falls and fall-related injuries among older adults are preventable. Prevention efforts may target those most at risk. So those are usually women, those aged 80 years of age and older people who are living alone, housebound, or have low income. We know that multifactorial prevention strategies are important to reduce the prevalence of fall-related injuries and deaths in Canada's aging population. Now, I did want to obviously focus on medication. That's my background as a clinical pharmacist at Sunnybrook. In terms of the background regarding medications and other fall risk factors, Mary Tinetti actually conducted a systematic review many years ago focused on community living older adults. And it was to identify that multiple impairments and conditions predispose to falls. And so we know that people that have had previous falls, that is a strong risk factor or strong associated risk factor for falls, other things such as balance, gait, muscle weakness, vision and hearing impairments, as well as medications and specific use of medications. And of note, falls and fractures share many risk factors. Now, medications are complex risk factors for falling. We know that diseases such as depression, heart failure, or hypertension also are attributed to increased risk of falls, but so do also the many medications that are used to treat these conditions. Now, common adverse effects such as unsteadiness, impaired alertness, dizziness are risk factors for falling. And the risk of falling among older adults increases with the number of medications consumed, independent of the medication indications or other confounding factors. But there's been a special emphasis on psychoactive medications. That is, medications that have sedative properties, antipsychotics, as well as antidepressants. These are the ones that are usually associated more strongly to falls. Now, I like using this slide to sort of capture the whole gamut of how complex polypharmacy is and some of the changes that occur with aging that affects the drugs and how we use and prescribe them and how people take them. Polypharmacy is a very common issue in older adults and increases the risk of inappropriate, unsafe prescribing for older adults. Now, there is no consensus definition to polypharmacy, but in most literature, it's usually generally defined as a numerical value or threshold. So usually 4 or 5 or more prescribed or over-the-counter drugs that someone is taking. Now, even though multiple medications a patient is taking may be deemed appropriate, polypharmacy is often a risk factor for adverse outcomes, including falls and injury, if polypharmacy is not managed properly. Now, we know that as we age, it has effects on pharmacokinetics. Now, that's a big word, and I know there are some, not everyone here is a pharmacist, but in short, what it is that it's the absorption, distribution, metabolism, and elimination of medications in the body, or what the body does to medications. And the result is there's a different response in drug therapy for older adults that we need to account for. And so with aging, our body composition changes. We put on more fat tissue, our lean body mass decreases. And because of these changes, the half-life of, let's say, fat-soluble drugs, such as benzodiazepines, which are a sedative, antipsychotics, antidepressants, this is usually increased and leads to a prolonged time for these drugs to exert their effects. So prolonged duration of action, which also means the potential for more potential for adverse effects or side effects from these drugs. Now, when you think about water-soluble medications, this also gets affected. And that's because our total body water decreases, our lean muscle mass decreases as we get older. And so older persons are more at risk of higher concentrations of these medications that they're taking. And this can be a potential toxicity risk with certain medications, things like lithium, digoxin, or even alcohol. Now, serum proteins also tend to decrease a little bit as we get older, but more so when we are frail or in malnourished persons. That decrease in the serum protein albumin, which is responsible for the majority of drug protein binding, results in corresponding increase in the free fraction of drug that is biologically active. So it's that unbound drug not bound to albumin that is exerting more effect. And because there's a more proportion that's more available, drugs that are highly protein bound, such as anticonvulsants like phenytoin or dilantin, valproic acid, which could also be used for certain mental health conditions, sedative hypnotics, they can potentially exert a lot more of their effects as well as side effects more frequently in older persons with low serum albumin. Now, in terms of metabolism of drugs, the liver is the main organ that is responsible for drug metabolism, and it is affected by aging. We know that liver size decreases as we get older, hepatic blood flow decrease, and so the enzymes that are responsible for drug metabolism that reside in the liver are a little bit less efficient. Now, there are variable effects when you talk about pathways and enzymes, and I don't want to get into a lot of clinical pharmacology here, but in general, there is usually decreased metabolisms of drugs that we can anticipate, irrespective of any other disease pathology affecting the liver. And then in terms of drug elimination, we know that drug elimination is usually dependent on our kidneys. Our glomerular filtration rate decreases with age after the third and fourth decade of life steadily. And so we also can predict that drugs can easily accumulate if not addressed. And now, lastly, just to think about it, if you have cared for many older adults before as patients, you probably have noticed a lot of heterogeneity between individual older patients. And that is another consideration we also have to take into effect. You can't make assumptions that, a person that is a frail older woman with multiple different comorbidities or disease states it would have a similar sort of presentation compared to a robust, healthy older woman. And so they cannot be expected to have the same sort of effects or reactions to a particular drug and dose. And so factors such as these, as well as inter-individual variability, frailty, in addition to organ function, changes as we get older, increase the complexity of managing drug therapy in older adults. Now, medications can contribute to falls through a variety of different mechanisms. Now, certain medications can contribute to orthostatic hypotension, cognitive impairment, more physical motor retardation, Parkinsonism, balance problems, dizziness, drowsiness, you name it. And I think Cheryl Sadowski and Derek Deeks has published on this before. I think Cheryl Sadowski has presented here on Loop and has shared her expertise on all the different ways that medications can contribute to falls and has published a lot on this. In addition, I would say that medications can indirectly contribute to falls. Now, for instance, a patient who is taking a diuretic may experience increased urgency and falls in the process of rushing to the bathroom, or it may change their gait while rushing to avoid a bladder accident or incontinence. Visual changes can occur when someone is taking a medication that has some anticholinergic effects, and this can lead to increased risk of falls. Think about also recreational drugs can also contribute to falls because of the CNS effects that they have. So an example, this gets often overlooked, but alcohol as a drug can affect balance and judgment, which increases the risk of falling. And this can potentiate these adverse effects in medications the person is taking. Now, I wanted to highlight some systematic reviews that and meta-analysis that have looked at and appraised the association between falls and different medication groups. A lot of it is related to psychotropic medications, cardiovascular drugs, and then others that are not psychotropic and not cardiovascular. Now, a lot of these meta-analyses have done their statistical analysis, and reporting was usually done with both unadjusted and adjusted odds ratios. And adjusted odds ratios is just a way to sort of try to address some of the confounding factors that may be involved in certain trials or studies. But across all these three systematic reviews and meta-analyses, there was substantial heterogeneity, both clinically in terms of the trials or articles or studies involved, the populations that were being looked at, as well as settings, because it varied between community, long-term care, or institutions. But if we looked at it really as an overview, again, as we know, a lot of psychotropic medications were associated with falls based on these odd ratios. And again, these were a mix of different studies, not a lot of randomized controlled trials. A lot were observational studies, cohort studies, or case control studies, and in different settings. In terms of cardiovascular drugs, we know that a lot of drugs that can affect blood pressure and volume status has been associated. But in this meta-analysis, it was actually loop diuretics were the only sort of pharmacological subgroup of diuretics that were sort of significantly associated with an increase of falling based on the adjusted odds ratio. It may be that loop diuretics can have a rapid and powerful diuretic effect compared to other diuretics used for hypertension, whereas loop diuretics tend to be used more so for heart failure or pulmonary edema. And these types of diuretics can cause more rapid changes in extracellular fluid, which could explain its association with fall risk. But as I mentioned before, because of some of the confounding that can be at play, residual confounding by indication is an issue with a lot of these studies. So, for instance, since people with heart failure may not pump their blood as efficiently, this may cause a decrease in blood flow to the brain. And so they're more likely to take multiple CHF meds that also increase dizziness and lead to fainting and falls. And interestingly enough, beta blockers were found to be associated with a reduced risk of falls. And then another sort of common class of medication that we've always classically attributed to falls, like digoxin, it isn't listed here in the adjusted odds ratios, but the meta-analysis, when they looked at unadjusted odds ratios, it did show for significant results for digoxin is associated with falls. And then lastly, in terms of the other non-psychotropic, non-cardiovascular medications, again, a lot of different studies that were examined, but opioids, anti-epileptics, and polypharmacy were significantly associated with increased risk of falling in the author's meta-analysis. Now, having said that, I also take into account that fall risk increasing drugs, when you think about it, any medication can be a FRID or a fall risk increasing drug, especially in an older, vulnerable adult. Now, definitions of a fall risk increasing drug vary in the literature, but they commonly include a lot of the classes that I talked about previously. Less frequently, they may include other cardiovascular medications, hypoglycemic agents, because it's intuitive that hypoglycemia can cause falls. And so as such, many of the medications are considered potentially inappropriate in older adults who have experienced a fall or fracture. And that's why I say it's potentially inappropriate. Because there may be good indications to be on those medications, but we have to think about it from a risk and benefit perspective as well. A lot of studies have included a lot of sedative hypnotics like benzodiazepines or Z-class drugs as FRIDs. And then also antidepressants are also commonly included in fall risk increasing drug lists. Now, beyond these two classes, again, FRIDs lists usually vary from study to study. Now, the other thing to think about when we're considering medications and falls are other mechanisms like postural hypotension or orthostatic hypotension. And this syndrome or symptom can cause considerable morbidity in both community-dwelling adults as well as institutionalized older adults. All older patients presenting with presyncope, syncope, or fall should be evaluated for postural hypotension whenever possible. We know that when you stand from a supine position, it actually drops about 10 to 15% of our blood to pool in the venous beds of the lower extremities of our legs and feet, as well as our splanchnic blood system. Orthostatic hypotension is commonly seen in older adults because of age-related impairment in baroreflex reflexes when they change from a supine to an upright position. Now, Frank Molnar has published a practical summary of the 4D AID acronym to help clinicians assess and prioritize contributing factors. So 4D stands for deconditioning, the dysfunctional heart, dehydration, as well as drugs. And dehydration can also involve drugs as well, things that can contribute to volume status, things that can decrease or worsen hypovolemia, as well as the other Ds there listed on the screen. This 4D AID acronym is helpful and practical, and it's also differentiated between whether you have a compensatory tachycardia or no heart rate increase. So failure of the heart rate to increase in the setting of a blood pressure drop, orthostatic drop, might be a clue to underlying autonomic pathology, or maybe they're on beta blocker use. Whereas if someone has an orthostatic blood pressure drop and they have some tachycardia, it could be suggestive of drugs or dehydration or intravascular volume depletion. Now, there have been several algorithms and guidelines to falls risk assessment and management, and a popular one from ages ago was about probably 10 or 15 years ago, was the American and British Geriatric Society's clinical practice guidelines on falls prevention. And people still use it, but there's also the World Falls Guideline that was recently published last year by Manuel Montero Odassa, who's also a Canadian geriatrician and clinician scientist, also based out of the University of Western, who was the lead author of this World Falls Guidelines. And the authors show that there should be sort of two entry points for falls risk assessment and management. So the first one is, opportunistic case finding for healthy visit when someone who may be at risk presents themselves. Or the other one is when the problem itself is the fall. So when older adults present to healthcare, the ED or the emerge as a result of a fall or fall-related injury. Now, when it comes to falls risk assessments, it should be multifactorial. I don't want to discount that, even though our presentation today is focusing on medications. But they recommend the use of for when it comes to medications and medication review, validated structured screening and assessment tool to identify falls risk increasing drugs when you're performing a medication review, and appropriate deprescribing of falls risk increasing drugs when possible should be part of multi-domain falls prevention interventions. Also keep in mind that good management actually of underlying acute and chronic diseases is important too. And so comorbidities, we have to keep in mind that can be optimized by medication and pharmacotherapy, as well as being able to reduce the risk of falls by having good treatments of these. So it can be complex when you're dealing with medications as well as comorbidities and trying to balance optimization as well as deprescribing. Now, there are numerous tools and frameworks that are available to identify potentially inappropriate drugs or medications and to facilitate that identification as well as look at potential for deprescribing. The World Falls Guidelines recommends using the validated structure screening approach and using these types of tools. Probably the most common one that everyone has heard about is the Beers criteria. Now, Mark Beers was a geriatrician who started this off back in the 1990s or 1991, I believe. And he led an expert consensus panel with colleagues in the United States. And the Beers criteria have undergone multiple updates, with the most recent one, I think this is the 7th iteration now, just earlier this year, published by the AGS. As well, there's also the stop and start criteria, which is popular in the UK and Europe. And this was developed by Dennis Mahoney et al. And this tool was similar in concept to the Beers criteria, created by a group of experts that looked at literature and did an evidence review, who identified drug therapies that were potentially inappropriate for older people, but organized based on physiological system. And this was also updated and published earlier this year, around May of this year. And then another thing that may be more familiar to US practitioners is that the Center for Disease Control and Prevention has published the Stopping Elderly Accidents, Deaths, and Injuries Toolkit, which is acronym short form for STEADY. And it's a suite of materials, posters, algorithms, and patient-facing material to help inform this tool. Now, there are other tools, because the things that I showed you before were part of like an explicit set of criteria looking at medications and falls. Other resources that are also out there are things that sort of quantify the nature of falls risk, namely anticholinergic risk or anticholinergic burden. And the two most common tools are the anticholinergic risk scale, as well as the anticholinergic burden scale. And the principle is that it quantifies a risk score based on the drug that a patient has and basing it on the level of anticholinergic activity. Some of the studies or articles used for these tools have in vitro studies or in vivo studies. They vary, and so they quantify this. Now, the anticholinergic burden score, the ABS, has an actual clinical calculator online. And so this actually allows you to actually put in a whole bunch of different medications to be entered. And then you can figure out, based on a medication list that someone is taking, how much anticholinergic burden someone has. And for those that are serious risks, someone would have to have a score of at least 3 or more. There's other approaches as well, a medication appropriate index, which is a list of questions to ask as you're assessing medication or medication therapy. Obviously, you have to also be familiar with drug references, product monographs, as well as a good foundation in clinical pharmacology can also help. And then you also have to look at the patient in front of you and how they present as well. Other patient info, there are other factors that come into play. Things that can also help inform decision making is things like clinical frailty scale, cognitive functioning, as well as physical functioning, and so forth. Now, there is no universally accepted definition to medication review, but generally it involves an assessment of the efficacy and harms of each medication prescribed. And for some of those of our attendees today, if you are a pharmacist, this may be familiar. And this is what we actually teach in school about how to assess medications for a patient. It's the IESA approach. And this medication review is supposed to be structured. It's a critical examination of a person's medications with the objective of reaching an agreement with the person about treatment, optimizing the impact of medications, and minimizing the number of medication-related problems or drug-related problems a person has. So I stands for indication, E is effectiveness, S is for safety, and A is for adherence. Now, a medication review can be performed in a variety of settings. It could be an acute situation during a hospital stay. It could be used periodically to reassess the benefits and harms associated with chronic medication use. It could be performed by a single reviewer, so by a physician, a pharmacist, a nurse, or another trained healthcare professional. Or it could be done as part of a multidisciplinary or interprofessional team approach. And it definitely advises that tools or criteria that I showed you earlier, such as the Beers criteria or the stop-start criteria or stop-fall, are examples of tools that could be helpful in this medication review. Now, optimizing drug therapy is an essential part of care for older adults. A systematic and stepwise approach to prescribing as well as monitoring those medications is essential. The first step in safe prescribing is to know an accurate medication history. So what is the medications that a patient has, but also what are they actually taking? A holistic approach to care is essential by knowing the patient's past medical history, their habits, their vices, their functional and cognitive status, what are their supports, what matters most to them also in terms of like preferences, goals, values, goals of care. And then with that information, one will be able to provide appropriate recommendations regarding medications. And so with a good medication review, one should be able to identify potential or actual adverse drug reactions or risk of adverse drug reactions or side effects, prescribing cascades, inappropriate prescribing, as well as underprescribing. We don't want to miss out on being able to optimize medical conditions as well that might adversely affect risk of falls or risk of fall-related injuries. And so given the complexity of all that, it usually requires a multidisciplinary or interprofessional approach, and pharmacists play a vital role in the medication review process. So the bottom line is, I would say when it comes to medication review, do not rely on pattern recognition alone. use a systematic process like the algorithm that I'm showing in front of you. And so this thought process helps when dealing with complexity and patients with complex conditions and lots of medications or polypharmacy. So I mentioned prescribing cascades. Prescribing cascades is an old term that Paul Rochon actually coined many years ago in the mid-1990s, where a drug's adverse effects may be misconstrued as a new medical problem or condition, which may trigger further prescribing, which may also cause other adverse effects and so forth. And that's how the term prescribing cascades come about. Now, most clinicians can easily find simple prescribing cascades where a drug is attributed to a problem and another drug is prescribed. But they can be challenging to identify for several reasons. Extended life expectancy is an issue, multimorbidity in our long living older adults now, as well as polypharmacy contribute to disease complexity in older adults. And so it can be challenging for clinicians to discern what is a symptom of an illness and what is a drug side effect. And so if we as healthcare providers are vigilant in looking for prescribing cascades when new symptoms arise, then certainly it will not be identified. Also, we know that in practicality, in real life, there are time constraints. We know that are facing a lot of our doctors and other clinicians. And so it can be a time-consuming process to screen for prescribing cascades. In addition, best possible medication histories, which are the starting point of doing a medication review, are often not obtained. It takes a lot of time to conduct accurately. For an older adult, easily on 10 medications, we know that it can take at least 45 minutes to do an accurate and thorough review. And sometimes we do not have that time to spend on that best possible medication history. And so practicing clinicians and trainees may not adequately question whether a patient's new symptoms could be caused by their current medications. And so one way to identify prescribing cascades is by creating a clinical process map. And so process mapping has its foundations in quality improvement, but process mapping can also be helpful in trying to identify prescribing cascades as well. And so this is just an illustration to a patient's presentation, symptoms, medications, possible side effects, as well as interventions. And so the thing you have to ask oneself is, could my patient's new symptoms be caused by a drug that they are taking rather than a new medical condition? Just like medication review, you need to have a process to find all the prescribing cascades. And process mapping is helpful in that. And so finding prescribing cascades is helpful for finding the big picture for a person. Now, this leads to our section on deprescribing. Just like prescribing, deprescribing is just part of the prescribing continuum. It's a process of decreasing, tapering, withdrawing, or stopping medications. Usually it's to manage polypharmacy, actual or potential adverse drug effects or outcomes, or inappropriate or ineffective medication use. We know that there are no set ways to deprescribe, but there are tools to help. There is a deprescribing protocol that was developed by Ian Scott and his group a while ago. And it's a 5-step approach that was published to help clinicians, to help them decide the order and the mode in which drug therapy could be discontinued. The approach identifies each medication an individual takes and making sure we identify what the reason or indication is for them, considering the overall risk of drug-induced harm, assessing each drug for its eligibility to be discontinued, prioritizing the drug for discontinuation, and then implementing and monitoring a drug discontinuation regimen. Now, one of my favorite resources or tools I like to share with other clinicians or learners is the algorithms and resources developed at deprescribing.org. And so some of you may be familiar with deprescribing.org. It's free. It's available on their website. And they actually received a lot of funding and CIHR grants to help develop this evidence review and have an evidence base for deprescribing. And one of my favorite ones I like showing is the sedative hypnotic deprescribing algorithm, because it helps clinicians identify whether a person should be on a sedative hypnotic to continue with it, or is there potential for deprescribing? And if patients are engaged and willing to try, it can provide some guidance on how to go about it. And what are some of the non-pharmacological ways to help improve um, people's symptoms as they're going through the tapering process of coming off a benzo or a Z-class drug. Now, the evidence is quite mixed on medication review and deprescribing. So there are two recent Canadian systematic reviews and meta-analysis regarding these topics. Ming et al. Published a systematic review and meta-analysis on the effectiveness of medication review as a single intervention or as a component included in multifactorial interventions. And this was specifically for preventing fall-related injuries in older adults. A medication review was found to be effective in preventing falls-related injuries and specifically fall-related fractures in community-dwelling older adults. But they did look at different settings as well. But the focus that they, or the evidence that they found was the association in more so in community-dwelling older adults. Now, Justin Lee and his group also conducted a systematic review and meta-analysis focused on whether deprescribing as an intervention in itself of falls risk increasing drugs decreased the risk of falls in older adults. And they found that there's a lack of robust, high quality evidence to support or refute the deprescribing of FRIDs alone as an effective falls prevention strategy. And so the author group looked at 5 randomized controlled trials out of a whole bunch that they had found and elicited. So they cut through a lot of other and excluded a lot of other articles and only looked at RCTs. And so they found that a deprescribing strategy did not significantly change the rate of falls nor the risk of falling over a period of 6 to 12 months. And this was only as a single intervention. They did note that although there are other reasons to deprescribe falls risk increasing drugs, it doesn't mean that clinicians should avoid deprescribing. So they did point that out as a caveat in their discussion. They recognize there's lots of other reasons to deprescribe medications, and they include things such as trying to avoid adverse drug events, trying to improve someone's cognition, or increasing medication adherence and reducing the burden of polypharmacy. And they also point out that it may be that medication-related interventions work best in combination with other interventions, not related to drugs. And so that takes us to this part where we think about multifactorial or multi-domain interventions. And so some of you may be familiar with the geriatric 5 M's or the 4 M's in the States when it first started out. It was part of the Institute for Healthcare Improvement in the US as part of an age-friendly health system initiative to improve care for older adults across different healthcare settings. And so it's evolved into the geriatric 5 M's, and it's supposed to represent a common sense, practical, easy to remember packaging of, let's say, the geriatric giants or geriatric syndromes to better define those care issues that reflect the expertise of all our clinicians, not necessarily just geriatricians or physicians in general, but all healthcare providers that work or specialize in geriatrics and work with older adults. And so these are evidence-based elements of high quality care to all older adults in your system. What matters most? The mind, mobility, medications, as well as multi-complexity. And the hand is symbolic because not only are there 5 digits and you can remember them, but they're all interconnected. And so that interventions in sort of one domain may actually affect several other things. And that's why multi-domain interventions may be more effective in a lot of things besides falls and falls injury prevention. And so when I sort of do my assessments, I always try to make sure that they are integrated into, let's say, a comprehensive geriatric assessment or a CGA, and that it's all packaged all together, not done just as a solo type of assessment and intervention. And so this would be an example of someone who comes in, who, based on the assessment, also finds that, they have a bit of mobility issues, some sensory issues, has been identified with an orthostatic blood pressure drop, with some tachycardia, has some cognitive impairment that could be potentially dementia. And so there may be some medications that we could deprescribe based on the falls risk, as well as the fact that they may be cognitively impaired. And we could also do some things to help with their pain because they have some osteoarthritis as well, and trying to avoid drugs that could increase their falls. So this is the point in our session that we're going to get everyone involved. So I'm going to start off this case with Leslie. So Leslie's a 71-year-old woman who presents to you. She has a past medical history of hypothyroidism, osteoarthritis, and heart failure. And she comes to you saying that she's recently experiencing unsteadiness and has had one fall at home. She didn't have any injuries as a result of the fall, but when you dig a little bit deeper, she says that she gets dizzy when standing up or getting up from a chair. Her medications are listed out there. And when the nurse in the clinic measures her blood pressure and does her orthostatic vitals, these are the results. Okay. So I know not everyone is a pharmacist, but I didn't try to do this as a trick question, and you don't have to be a pharmacist. This is just your thoughts. Which of the following medications could be contributing to Leslie's falls risk? And I didn't make any sort of tricky dosing issues or anything. These are standard doses that we would recommend in a typical patient. So is it A, dapagliflozin 10 milligrams a day, levothyroxine 75 mics a day, furosemide 40 milligrams twice a day? Could it be none of the above? Or could it be E, A, and C? So I'll let Michelle run the poll. You have some time to make a selection, and let's see what you say.
Thanks, Chris. We've got about 45% of people have responded. I don't know if it's helpful if you go back one slide, maybe. I was just thinking, do people want to see the parameters, just in case people were forgetting? But people are responding, so it doesn't seem to be too much of an issue.
Yeah.
I'll give it another 30 seconds, give people a moment to think about it. Alrighty, I'm gonna close it now and I'll share the results.
Great. So some people picked up that, it could be furosemide, which is listed as a potential falls risk increasing drug. Some people selected dapagliflozin, which is a newer medication. I definitely put it on that list because it is not typically listed or as part of an explicit criteria tool like Beer's criteria, stop-start associated with falls. And levothyroxine is not the correct answer. And great to see a majority of people picked A and C, which is the correct answer. And I'll tell you why. So some of you may be familiar with SGLT2 inhibitors. So these are sodium glucose transporter 2 class of medications. These class of medications were originally developed to help treat type 2 diabetes, and they lower glucose by blocking glucose reabsorption in the proximal tubule, thus leading to an excretion of glucose in the urine. And so that's how they work. But because of this, there can be an osmotic diuresis effect. So people pee out a lot when they're on SGLT2 inhibitors. But apart from use in the treatment of type 2 diabetes, they have actually gained a lot of prominence and usage because they have been shown to provide a lot of cardiovascular benefits in people with heart failure. And there's also benefits in patients with CKD, or chronic kidney disease. Now, SGLT2 inhibitors are not considered a traditional diuretic for heart failure, but it is associated with higher volume of diuresis, or diuretic effect, especially when combined with loop diuretics. So the Canadian Heart Failure Society, and I think a lot of other guidelines as well have talked about this, have developed a practical algorithm for the use of SGLT2 inhibitors. And so it incorporates deprescribing, especially when someone is on another diuretic as well, especially a loop diuretic, because they know that volume depletion can occur, especially more so in older adults. And so it may involve either a dose reduction or even stopping a loop diuretic if volume depletion occurs. On the flip side, and not related to the case, there's also the issue of deprescribing other things related to diabetes care. And so they also put in a good point that if people are on insulin or sulfonylureas, which are high-risk drugs and causing hypoglycemia, which could also be associated with falls, it also suggests dose reductions. And so if someone is experiencing hypoglycemia, they should actually stop their sulfonylurea, like glyburide or gliclazide, and consider dose reduction in this. So I just wanted to show this as a good example of how deprescribing can occur and how we also cannot just rely on explicit criteria of falls risk increasing drugs. All right, so let's get into our second case. So Regina is an 80-year-old woman who sees you today for her opinion of her osteoporosis therapy. She's not too complex in terms of her past medical history. She has a COPD as well. And she's been well and adherent to her weekly alendronate, so that's her bisphosphonate or osteoporosis therapy, in addition to taking some vitamin D, and she gets dietary calcium. And she had a hip fracture due to a fall 2 years ago. So she's been on alendronate therapy ever since. Now, just like a lot of people with access to the internet and Dr. Google, her friends have told her that she should stop her alendronate, or at least discuss stopping her alendronate with you as your healthcare provider, because it might cause fractures and jaw problems. It's all in the news. So this comes to our second poll. Should Regina stop her bisphosphonate, her alendronate, for osteoporosis now due to concerns about adverse effects? And so this is an opinion question. Is it yes, no, or don't know?
Gonna give it another few seconds and then I'll share the results.
Okay. So a mix of answers, but a majority of people said no, but some are sure. And so this is good. So we'll get into that. All right. So, we know that fracture risk increases with advancing age as a result of declining skeletal strength or bone mineral density, as well as with the increased risk of falls. And in Canada, more than 2 million people live with osteoporosis. And every year, about 150 people per 100,000 suffer a hip fracture, which can be a devastating and serious consequence of osteoporosis and a fall. fractures lead to increased morbidity, excess mortality, decreased quality of life, as well as loss of autonomy and dependence. And just like falls, when you have had a fall, you're at risk of subsequent falls. And so once you have sustained a fragility fracture, you're also at high risk of subsequent fractures. And osteoporosis traditionally has just been defined as, a bone mineral density of 2.5 or more standard deviations below peak bone mass. And so you'll see those BMD results for patients that get a bone mineral density test. It says a T-score. And a T-score of less than or worse than minus 2.5 is an indicator of increased fracture risk. But it doesn't necessarily just depend on that bone mineral density test to have a diagnosis of osteoporosis. A clinical diagnosis of osteoporosis can be made in people aged 50 years of age and older if they have sustained a low trauma fracture. And a low trauma fracture from standing height or when low forces applied to the bone is judged to be insufficient to fracture normal bone is considered a fragility fracture. And so these low trauma fragility fractures to the hip, to the vertebra, humerus, or a pelvic fracture in this population, or if they've had an absolute fracture risk based on a scoring tool of 20% or more over the next 10 years, deem someone as being at high risk for fragility fracture and having a clinical diagnosis of osteoporosis. Now, Osteoporosis Canada just released an update to their clinical guidelines just last month. And it's been over 10 years in the making since the last guidelines were from 2010. And so they address the issue of duration of therapy and this adverse effect that's hit the media. And it's related to a person's risk of fracture, balancing their risk of this rare drug-related adverse event. And the suggestion is that 6 years of therapy is probably a reasonable duration for individuals with a history of a hip fracture, a spine or vertebra fracture, or someone who's had multiple non-vertebral fractures or newer ongoing risk factors for accelerated bone loss or fracture. If they're more intermediate, then maybe stopping after 3 years and then reassessing is also reasonable. It's important to know that they also recommend monitoring should also be in place. And recommendations at this time is bone mineral density testing 3 years after starting drug therapy or after stopping bisphosphonate therapy, i.e. the so-called drug holiday. Now, inadequate response to treatment should be considered when someone has more than one fracture or when it's determined on a bone mineral density test that there has been substantial bone density decline, even though someone is taking an adequate course of treatment. And typically, an adequate course is at least 1 year. Now, fractures or bone density decline can occur with therapy, but they do not always indicate inadequate response to treatment. And there could be other reasons, such as secondary causes of osteoporosis. Again, if you haven't addressed falls risk factors, there's also issues with bone mineral density imprecision errors. So it is complex in terms of decision making, but they also emphasize that serious rare side effects, such as atypical femur fractures, as well as osteonecrosis of the jaw, are extremely rare. Now, bisphosphonates are potent inhibitors of osteoclast-mediated bone remodeling or bone resorption, and they bind to bone and have a long half-life, especially when bound to bone. And they can be in the bone or the skeleton for many years. And they do vary a little bit in terms of which bisphosphonate someone is on, but how long they're exposed to it. But consequently, once someone stops taking a bisphosphonate, the bound bisphosphonate in bone cells or bone tissue provides usually residual pharmacological action for many years. And this has been looked at in several studies with alendronate as well as risedronate and zoledronic acid. And this is in contrast to other anti-resorptive therapies in which when you stop a drug, like the injection denosumab, its activity is actually quickly lost after discontinuation. So it actually depends, the drug holiday actually depends on what osteoporosis therapy the person is on. And so this drug holiday concept only applies to bisphosphonates. But they do address the issue that there may be harms with excessive duration of bisphosphonate treatment, depending on someone's risks for fracture. Now, context is key. This figure was actually done almost 10 years ago. This study was looking at a comparison of the absolute risk of bisphosphonate-related ONJ as well as atypical femur fracture compared to the risk of suffering a major osteoporotic fracture in untreated postmenopausal women, depending on their fracture risk. So they could be low risk, moderate risk, and high risk. And so you can see that the incidence of these events per 100,000 person years for high-risk persons at risk of fracture, the benefits of taking bisphosphonate therapy for 3 to 6 years far outweigh the potential harms. And so over 5 years out of 100,000 people taking a bisphosphonate, it's found to be that about 2,500 people will avoid a fracture, and 25 people may experience a side effect like atypical femur fractures or ONJ. And so the context is to think about like when you're thinking about decision making and teaching patients about what are the risks compared to other things, death by murder, motor vehicle accidents are a little bit higher. And then AFF at the 2-year mark, and I don't know if you can see my cursor here, it's pretty low. But as you can see, when we extend it out to about 8 years, the risk of one of these AFF events is a bit higher. And so that's why the recommendation is 6 years with reassessment. Lastly, let's go on to our last case. I know we're running out of time. Jerry is an 88-year-old male. His past medical history is there. He lives with his wife, and they have had a PSW help for housekeeping, bathing to help Jerry. He's dependent on his wife and PSW for IADLs and some assistance for bathing and dressing. He's had another fall this year. It's second in 1 year. He's had no serious injuries, fortunately, but he is on an anticoagulant for his atrial fibrillation. And the question comes up, should Jerry continue on anticoagulation therapy with apixaban? So again, we'll give you some time to make a decision on this.
Thanks everyone for answering. I'll give it another couple of seconds, but we'll move through it pretty quickly. I know we're a little bit over time. We have a couple more slides to get through and a couple questions. So all of this will be part of the recording. Thanks to those who have been able to stay with us up until this point. And I'm going to end the poll and we can share and get on to the rest of the presentation.
Great. So it's a bit of a mixed bag here. Some people say yes, some people say no, some people say unsure. And that's quite common. We do know that under-prescribing, underutilization, and underdosing of anticoagulants occur more commonly in older age patients. And the most common reason is the concern about falls or frailty due to concerns about bleeding. Now, the Beers criteria that I showed you have listed 2 of the anticoagulants or the direct oral anticoagulants to be used cautiously. Dabigatran lacks some safety data in those with very poor renal function or renal clearance. And then rivaroxaban, real world data has shown that it is associated with a higher rate of GI bleeding compared to other direct oral anticoagulants. Now, we know that a person's dementia, their cognitive impairment is a falls risk factor. But falling also does not always equal bleeding, and they don't always hit their head. And so there's been studies looking at this from many years ago when warfarin was the only anticoagulant, and looking at whether the risk of falling with a possible increased risk of a subdural hematoma should influence choice of antithrombotic therapy. And they found that a person would have to fall 295 times in 1 year, almost falling daily, for the risk of a subdural hematoma to outweigh the benefits of anticoagulation with warfarin. And then recently, there's also been another decision analysis model looking at direct oral anticoagulants. And they found that someone would have to fall over 45 times on rivaroxaban or over 458 times if they were taking apixaban in 1 year for their quality adjusted life years of a directed oral anticoagulant to be lower than that of aspirin. So it's just some contextual studies that have been done on this. Now, the other thing is that, well, what about if they do have anticoagulation? What is the risk of having a hemorrhage? And so advanced age and anticoagulation, always perceived to be associated with an increased risk of intracranial hemorrhage after a head injury. And we know that you should think about, what is the risk of having a stroke when someone has atrial fibrillation versus what is the risk of someone having a bleed in the brain. And we know that it's about comparable. 8.1% of a stroke for those with AFib with at least one risk factor, and about 8.9% of an intracranial hemorrhage with a head injury. But what does the data show about that? So there's been some Canadian studies here in Ontario that have talked about this. There was a population cohort study done in Ontario that evaluated the risk of intracranial hemorrhage after an ED visit for head injury among people 65 years of age and older, whether they were taking a warfarin or a DOAC. And so what the data showed was that in actuality, older patients on warfarin who presented to the ED with a head injury had an increased risk of intracranial hemorrhage compared to people on a newer DOAC or compared to people not on anticoagulation. So the risk seems to be higher for people on older therapy like warfarin. So sounds like DOACs or direct oral anticoagulants do not increase the risk of intracranial hemorrhage after a minor head injury or fall compared to those who are not taking anticoagulant. But the other issue that we have to think about is antiplatelets. The risk of intracranial hemorrhage may be increased among patients treated with dual antiplatelet therapy compared with aspirin alone. And so this is commonly done in people with acute coronary syndromes or people with MIs or people that have had percutaneous coronary interventions and putting a stent in. So I think we have to pay attention to those people as well in terms of antiplatelets and risk of ICH. So I know I've gone over time, but thank you for attending. These are just some of the key takeaways. Shared decision-making is really crucial though for whatever decision we always make. We need to account for patients, caregivers, as well as looking at emerging evidence and data and guidelines to help make decisions that benefit patients. So thank you for attending and happy to take any questions.
Great. Thanks so much, Chris. We've got a couple of questions. We may not be able to get through all of them. I think we'll stay on until 1:15, maybe 1:20 if we can. I do have a meeting to get to, so we can't stay on forever. But the first question here is, how do medications impact peripheral neuropathy?
Yeah, good question. So some of the findings are related to direct toxicity, especially chemotherapy can cause peripheral neuropathy. There are also ones that are idiosyncratic. So we know that one of the antibiotics, like nitrofurantoin for treatment of UTIs, is quite common. And it's not actually related to the antibiotic itself. It's actually related to exposure. So prolonged duration to nitrofurantoin is a risk factor for peripheral neuropathy. It's also listed on the Beers criteria for that purpose. So treatment of acute UTIs is okay. Prevention of UTIs for giving that antibiotic 6 months to a year is probably not recommended for that. And there's also nutritional deficiencies that can be induced by medications that lower B12. That can also be a risk factor for peripheral neuropathy. So patients that are on metformin for diabetes can have reductions in their B12 absorption, as well as people that are taking PPIs or proton pump inhibitors. So those are just some of those examples.
Great. All right, the next question is asking if you see serotonin toxicity commonly, and if you think this adverse reaction is recognized very often.
Yeah, fortunately, I haven't seen too many here at my current practice. We used to see a lot in the ICU, but sometimes they were due to medication misadventures, overdoses, and so forth. But I would say that, it's a good idea to always think about all those serotonergic agents that people are taking, whether it's the antidepressants or antipsychotics. And I will say, like, one of my pet peeves, one medication that I always try to avoid is tramadol. People often are prescribed tramadol for pain, but clinicians who don't have a lot of experience with tramadol also have to realize that it also has norepinephrine and serotonin effects as well. And so people can run into problems because it's like an SNRI or another antidepressants as well.
Great, thank you. All right, the next one is any difference in efficacy between biophosphonates and, oh, I don't know this one, denosumab?
Denosumab, yeah. Yeah, so, bisphosphonates are still recommending it in the new guideline, the Osmosis Canada guideline, as first-line treatments for fracture prevention, as well as secondary prevention after someone has had a fragility fracture. Efficacy is still great for both of them. Now, there are some contraindications to bisphosphonates, and not everyone can take them, especially if people have poor renal function, and that's why denosumab or Prolia might be an alternative. But the also thing is that convenience is also an issue. Bisphosphonates are taken orally, except for zoledronic acid. It's an IV infusion once a year. But denosumab is a sub-Q injection given every 6 months. And sometimes in some provinces and territories, because it is a more expensive medication, there may be prescription limitations or limited use criteria that people have to have tried another alternative agent like bisphosphonates before proceeding to denosumab. But good question.
All right, our last question here is, do antipsychotics / antidepressants increase the risk of falls in wheelchair-bound or non-ambulatory populations? They ask, rather, don't they help prevent the fall by settling them down in the wheelchair or bed?
Yeah, that's a good question. And I wouldn't say there's probably not a lot of direct literature or evidence. So in someone who is more wheelchair bound or bed bound, I will say that, when people are being exposed to a lot of psychoactive agents like that have antidepressant or CNS depressant activities, it is being used as a chemical restraint. And we know in general that not just physical restraints, but chemical restraints can increase their risk of falls. And people don't have to be standing upright to fall. They can be actually in their wheelchair, they can be in bed, and they can actually fall. So I would be hesitant to say that, I would be, not thrilled to have someone on multiple psychoactive medications, even if they are wheelchair bound or bed bound, that they're probably safe from a falls perspective. I'd probably say it's probably the opposite.
Alrighty, and those were all of our questions. So I will wrap us up by starting with a big thank you, Chris. It was fantastic to have you. Really great presentation, great overview of medication considerations with that fall perspective, and loved having some case-based learning, which I know our audience always appreciates. And thanks to those who are still on the line with us. When the webinar ends, you'll be redirected to an evaluation survey. If you have the time, please do fill it out. Otherwise, the link will be sent automatically from Zoom. It'll be kind of in that post-webinar email from Zoom. And like I said before, you'll be getting a post-event email package from me with the recording, the slide link, and all the other information that I started things out with today. But thank you again, Chris, and I hope everyone has a fantastic afternoon.
Thank you. Take care, everyone.